Welcome back to day 3 of the Within Health 2023 Summit. My name is Jamie Singletary, and I am so happy to be the host for this session. It is my pleasure and my honor to introduce my colleague, Rebecca Brum, who is the Chief Clinical Officer of Within Health. And today, she is going to be speaking about peering into the microscope of resistance. Before I turn it over to Rebecca, I just want to remind you all that we do have the chat feature available. So if you have questions, concerns, or comments that you would like to send to the presenter or make about the presentation, please utilize the chat. I will also have my contact information in the chat should you have any questions, concerns around how to obtain your CE or CME certificate, as well as contact information for CEO should you have any technical difficulty. Without further ado, I will turn it over to Rebecca Brum. Thank you.
Thank you so much, Jamie. Welcome, everybody. It's such an honor to have you joining our summit and to be welcoming you to one of my really favorite topics, which is really looking at patient resistance and getting a deeper understanding of some of the ways that resistance shows up in our patients and some of the things that we can do to overcome it. With our time today, we'll talk a little bit about what is resistance and how does it show up in our care? Really talk about, let me back up here. I've changed the topic or changed the title of this presentation. It's always been about resistance, but the title has morphed a little bit. And even if I had the opportunity to morph it one more time, I would put, instead of peering into the microscope, it would be peering into the reflecting pool or peering into the mirror, because what I've found as I've continued to look into this topic and do research around it is that we as providers have a big impact on resistance, and the way that we show up has a big impact on what happens with that resistance. So I want to take some time to explore the humanity, how we show up, how we're impacted by treatment resistance, talk about how we can stay present and intentional and how we can increase our effectiveness when met with resistance. And then really the ultimate goal of all of the information I'll share today is to help us as providers attune with that resistance and use it to deepen the therapeutic opportunity for growth. So I will often say that resistance is why clinicians have jobs. And so what I mean by that, and many of you have probably found yourself in this position, I'll often have a client that says, I don't know why this is so hard, or I know what to do, I just can't get myself to do it. And I'll often remind them that that's exactly why I'm here, exactly why we're doing what we're doing. It's not the knowing what they need to do that needs to be changed. It's getting into practice, putting into the work and the action. And our job is to help them figure out what is serving as opposition, figure that out. So maybe that's meeting a need in a different way, or grieving a need or a loss. And what we often find as opposition to therapeutic goals and growth is fear of what's on the other side, potential for loss of what we want or what we think we need to have. Sometimes the therapeutic resistance is serving as protection or has a functionality to it, or a functionality that existed at one point in time. And when we can be aware of how we show up with that, how we meet resistance, especially in some of those more difficult cases, we can have the opportunity to understand more of its purpose and then grow more clear and have a deeper knowing of what that patient needs to be able to move forward. So I love an opportunity for you all to think about some of the things that I'll talk about and really think about how they show up for you in the work that you do and the practice that you have and the care that you provide. So when I brainstormed, how does resistance show up in my work? These are some of the things that I came up with. And I can imagine that many of you maybe have some different things. And would love for you. You're welcome to throw those in the chat just to kind of share a little bit how you see resistance show up. We often can see it as not completing things, not showing up for appointments, sometimes giving that like, okay, yes, I can do this. I'll come to an appointment, but I can only do it at 6:30 on a Friday. Often too, we see, especially at higher level care, some of that mistrust with one of the providers on the team, or with the recommendations, or with care in general. And it's interesting, I've often found this to be the case with clients who maybe have, I'll say, trauma, but also maybe just life experience of not being able to trust authority figures. Maybe that's parents, or maybe that's teachers, that really have a hard time with trusting that somebody in a position of authority might have their best interests at heart. And so sometimes that shows up as resistance to care recommendations. We might also find somebody with low engagement, or sometimes we can find interpersonal issues come up in our work, and criticism, anger, hostility towards the team. So when I think about resistance, and I think about my own role, often my role within is to work with the cases, and to be present, be available, and to assist with some of the cases that are having some of the biggest struggles. And often when I think about struggles, it's resistance. It's lack of engagement. It's all of those things that would maybe fall under that heading. So I have had a lot of experience working in these cases that feel like they have a struggle to move forward, to progress. And so when I think about those situations and I think about what are some of the biggest heartbreakers around those, these are often the cases that we're, in the shower, or laying in bed at night thinking, what is going to help this person move forward? What is the thing that is stopping this person from being able to take this next step? And so I can imagine that you all are here because at the end of the day, you really want to provide effective care. So that's what I want to start with is what are the things that will help us to be as effective as we can in our treatment? There are two things, collaborative versus directive care and feedback-informed care, that really stand out in the research as being part of providing effective care. So I want to highlight a little bit in this quote. The benefits of a collective approach are especially pronounced in individuals with eating disorders, where low motivation is common and is a key predictor of treatment outcome. Collaborative treatment approaches in this population have been linked to higher motivation for change, greater treatment satisfaction and adherence, and better patient outcomes. And I would say it's fair to assume that all of us would love those things. Higher motivation for change, greater treatment satisfaction and adherence, and better treatment outcomes. So there are components to collaborative care. And the things that will reduce a provider's ability and willingness to be collaborative include their personal distress levels, how they rate to their own distress, and the way that they relate to others' distress. When we look at relating to our own distress, self-compassion is a really important component there. This allows us to stay present with difficult and challenging emotions, It allows us to really think about what's coming up for us, why we might be reacting internally or externally the way that we are. It allows us to set that aside and to continue to stay focused and present with what we're doing. It allows us to have a greater ability to maintain distress tolerance. And it allows us to stay committed to this non-directive approach. I'm thinking about this morning, life always gives me opportunity to challenge myself and ask myself if I can stay committed to the things that I'm talking about. And I have a 15-year-old who I cannot for the life of me get him to consistently do his chore of doing the dishes. So still trying to kind of figure that out. We've done a lot of collaboration, a lot of openness, a lot of dialogue. And this morning, after we did a lot of that, I diverted from a collaborative approach and said, get down here, do these dishes, do not do another thing until you've done these dishes. And that just reminded me that we are human. We're human in sometimes the best of our intentions. We don't follow through on that because of other things that are happening for us. And I became aware of that personal distress that was happening for me and what my day entailed, and no longer stayed committed to that non-directive, collaborative approach. Another important component is compassion for others. This allows us to join. And if you're a clinician, if you're a provider, you understand that word join means attune, listen, metaphorically kind of walk side by side with a patient in their times of difficulty, to validate, to really stand in understanding what is contributing to that person feeling the way that they are, putting yourself in that person's shoes to understand what it might be like for them, what it must be like for them. And then that compassion for others is what really helps us to tailor the unique approach for each patient. So here is where I want to transition into feedback-informed treatment. And this is our ability to utilize patient feedback. I'm going to move you guys here just a little bit out of my way. Okay. So feedback-informed treatment is an approach that really became a thing by first asking the question, what is it that makes some providers more successful and effective than others? And they went through the normal things that you and I might guess, including training, what continuing education the person partook in, how much continuing ed they partook in. Were they an LPC or an LMSW or a PsyD? What kind of supervision hours and experience they had, and how long they had been in the field. And it turned out that none of those things were the determining factor in somebody being more successful or less successful as a provider. What they found was that the most effective clinicians are those that regularly and systematically solicit feedback on the status and progress of the therapeutic relationship. So 2 pieces there. They're regularly asking for feedback, and they have a system for it. And it's not just, is this working? It's, how is our relationship? And when they did that, they were found to significantly increase treatment outcomes, increase client engagement, and reduce dropout. And again, right, these are all things that we really want to happen for our clients. There's a couple of key features here. When we elicit feedback, we have to create a culture where it's understood that we want that it's an important, welcomed element of the care. By doing this, we help the clients to understand that almost that they're the magic ingredient to the treatment. We show up with this, and they bring this. And with that together, we form the care that is exactly tailored to their uniqueness. It also helps them to understand that this is a process. We are not going to put those two ingredients together and bam, have the exact right thing immediately. It's going to take time. It's going to take feedback. It's going to take relationship building and trust to be able to ask and to tell what things are working and what things are not. And it has to be done in a formal data gathering way. This was so shocking to me when I researched this, that many of the clinicians thought that they regularly did that. And so they went on to study that. And what they found was that as clinicians, we were all over the place, and we were pretty inaccurate in our prediction of how well people felt attuned to us. So it was really determined that this formal data gathering and consistent data gathering from the client was the most effective way for that relationship to be honed in a way that was fitting to the client. I want to share this as a tool from Feedback Informed Treatment. This is called the Session Rating Scale, or the SRS. This is a Googleable document. And this is a tool that is provided at the end of every session. And the client just puts a hash mark right on the continuum of where they felt like things aligned for them. And then when I've used this tool, I've really liked to leave a little bit of time to discuss and to kind of get an idea of what would have moved this along the continuum, or what was it about today's session that really was a good fit for you. And it can just be a quick talking discussion and regular feedback to understand and to help the client to understand the feedback that they need to give in order to make the process as strong as it can be. I also want to talk quickly, just for a slide here, about measurement-based care. Measurement-based care is something that often goes hand in hand with feedback-informed. Measurement-based care is a little more integrative with different measurement tools. So for those of us in eating disorder care, we might have our EDEQ instruments that we like. But measurement-based care really says we are going to have regular intervals that will show us that with this tool that you want to use, that is to your maybe therapeutic liking. But we're going to use this tool to help to measure and get a sense of how your treatment is improving. It's a piece of the puzzle. It's not all of the puzzle, but it's an important piece. And this will help clients to set the expectation that in care, you should start to feel differently. You should start to make improvements. And if we don't see that, we need to tweak things. The data will show us where things are working and what things need to be adapted. It will also help to work on that alliance, continued feedback, continuing to elicit the client in their expertise helps to build self-mastery as well. And last thing on this one, it's important, and I really love the emphasis on the art of the discussion around data here. So the data won't tell us one direct thing, but it will be a starting point for a conversation about how to fine-tune things, what maybe is a mismatch between what we're finding and what we're seeing in practice, and will just yield a lot of rich data to help us understand the client more. Okay, I am going to shift gears here. And there's two more parts. Let me make sure we have time for all of them. I think we do. Two parts here. I'm going to do the next part somewhat quicker than the last part. I'm going to go through tools, my favorite tools for therapeutic barriers and resistance. But then I would also like to spend the next part with a little bit of time for reflection for all of us that are gathered here today, because we often can serve as resistance and barriers. So creating a space for some self-reflection so that we can be able to also consider ourselves in the work that is the most challenging for us. I really like parts work for those really challenging stuck pieces in therapy. And parts work, I like IFS the best for this, but there are a lot of ways and modalities that acknowledge and work with parts. It doesn't have to be IFS for you, but this is the one that I'll use for the lens for today. A lot of times with a stuck part, we can take opportunity to look for and to acknowledge that there is a part, and this part is, like I said, a part, but not the whole. And it allows us to have an opportunity to seek knowledge of if there is another part that maybe feels differently. In our work, we can acknowledge that a part of them might be feeling something when there's a strong reaction. We might attend to that strong reaction as being activated as protection from a previous time of pain or harm. I really like IFS for the intention that it has, that there are no bad parts and that all parts have what I'll call functionality to them, positive intention, even when they show up in ways that might be destructive to the person. Normalizing parts to the patient is a really important thing to do. There are often times, and in common language, where people say, part of me feels like this, but another part of me feels like this. So we can normalize, it's normal to have that feeling. And it would be normal if another part of you felt opposite. So you can say, I'm hearing that you feel this way about that. Is there any part of you that maybe feels differently about that? So asking for curiosity from the individual to just assess if there's any part that feels differently or holds a different belief about that. And a really strong tool for this is being able to say, and we all know the magic wand question really well, if this was a magic wand and I hit you on the top of the head and allowed you to be able to stop doing this today in this moment, what would that part be afraid of if that happened? What would that part lose? What would that part worry about? And oftentimes I'll have to say, okay, I need you to completely abandon all logic here and think only from this part. What would that part be afraid would happen if it stopped doing what it does? And this is where you can get a lot of feedback and understanding, and even understanding that the client is unaware of. Parts work in its relevancy and applicability to resistance, really, we can start to melt some of that when we can encourage awareness, compassion, and healing between the self and the part by recognizing that a part has been carrying protection, and understanding and providing compassion to that part for the beliefs that it's held, for potentially the pain that it's needed to hold, for the way that it has held beliefs that the person needed that. Often in IFS, the belief is that the part may even resent the fact that it has had to do that job or has had to carry that. And when we can help the person not stand with their arms like this to the part, but kind of bring in and hold and service what they call the self in the situation, then the part no longer has to act in such extreme ways. And so in the attempt to reconnect with the self, sometimes people call this wise mind, or I've heard it referred to as the healthy parent, whatever it is for you as a practitioner, getting the patient to also say, okay, yes, I hear that a part of you feels this way about this. I'm wondering if yourself feels any differently about that, or if you were thinking through only the lens of self, would you view this any differently? I also really like schema therapy, and I'll say I could do a whole presentation on IFS and schema therapy, and we don't have time for that today. But I do really believe in providing tools. If you show up for a presentation, you want to walk away with some things that can be really helpful for you. So I think even in a quick form, a quick time that we have together, I can offer you the Young Schema Inventory. So if you Google YSQL3, and you might have to put Young Schema questionnaire long, because you will also get some computer terms that are not relevant for you. But if you Google that, you will find this document that is, I want to say it's like 265 questions. And it's on a Likert scale, 1 to 6, 1 being not me at all, and 6 being, yes, that's completely me. It will go through, and I'm going to move forward here to this slide. It will help to identify some themes in your client's belief system. These 18 early maladaptive schemas are the themes that it will help to identify. And I'll back up here. When you can start to identify, the scoring for the YSQL is online as well. When you look at the YSQL3, you will notice that after every maybe 5, 6, 7, sometimes it's a little less or a little bit more, you will find 2 letters that are very small underneath that set of numbers. So if you look at maybe the first one might be like number 7, there'll be a small AB. And when you're scoring, you'll look through some of the blocks that score the highest. And that will indicate what schemas the client is endorsing. And you'll notice that when they're answering 5 or 6 to the beliefs that are in that subset, those are usually the beliefs that the part buys into or believes. So I really like this tool, even as just a starting point for understanding a client, or for a point that feels really stuck, because it feels like it takes a quick detour to really sussing out what are some of the beliefs and barriers that the part is operating from, and getting right to the heart of trying to work with, challenge, grow beyond some of the beliefs that keep the client stuck. I also really, really have found the validation sequence from emotion coaching, from emotion-focused family therapy, to be incredibly helpful in practice as a clinician as well. So emotion coaching really is geared as psychoeducation and skill training for families. And this validation sequence, which I'll show you here in just a second, is used to help the patient regulate, to help them. When we think of somebody who's activated, we think of them as kind of having their elevator door shut, unable to open themselves to the information that might be being shared, even to flexible cognitive states and logical thinking. So this really is about helping the client to regulate a little bit more, helping them to feel attuned to. And it also serves the purpose of increasing the awareness of their thoughts, what's driving their behavior, the thoughts and the feelings that are driving the behavior and action, which has the intentionality of increased self-awareness and self-regulation. So let's talk about this. Let's look at this in action. Adele LaFrance is the one who came up with this and who I was trained by. And I remember that she said, think of the Wizard of Oz, and I've never been able to forget it because of that. So I also want to offer that to you all too. This because will help you to remember that the three becauses are really what drives this. So you start with a perhaps statement, I'll call it. So not a definitive statement, but a statement that would say, I could imagine that you, or it would make complete sense if, or if I put myself in your shoes. So a statement that kind of sets up the undercurrent of, I'm imagining what it feels like to be where you are. And then you validate an emotion or the urge, the thought, the behavior, or even the silence that you're experiencing with that person. So I am going to, let's do one today with us. I'm going to do it about my son since I shared that story. Probably what I should have done. So I'm going to say, I can imagine that you really don't want to do the dishes before you go to school today because you had to get up early already. There's only a little bit of time to catch your bus. And because you have baseball and homework and friends, and this feels like one more thing on your to-do list. So again, this is really asking, and the hardest part of this, and the part that I often end up needing to spend some time on with parents, is taking the time to understand why somebody might feel the way that they do, might behave the way that they do, might feel the urge to have the urge that they have. So it's about taking the time to consider 3 reasons why it would make sense for this person to feel the way that they do. What I don't have here, which comes next, but I think it's the natural thing that most people do, is to provide emotional and behavioral support. So with my kiddo, I would say, I really need you to do these dishes today, though. And let's see if you can set the timer for 5 minutes and just get it done quickly, right? It's emotional and behavioral support. We're all really good at that. But it's a much different story if I help him to understand and I put myself in a place of understanding what might be serving as his resistance to doing this chore. And then I have attuned with him. And then I provide that emotional support and the behavioral intervention. Just quickly, if he were to come back and say, yeah, I'm mad and I feel like you never listened to me, I would just do that sequence again. So I could understand how you felt like I don't listen to you because you've told me that you're overwhelmed at school, because I know you have 15 minutes before you need to catch the bus, and because you really do have a lot on your plate right now. So the sequence really lends itself to continuing to stay attuned and connected, and it helps to build that person to build their awareness of what's going on for them, for their reactivity. This is an amazing tool, and when I have longer to do this, I'll go into each of the pieces, but for the sake of time today, I'm going to go through it just a little bit more quickly. But I really love this tool. It's called the Precursors for Change. And what Fred Hanna did was identify 7 components that are necessary for change to happen, and then created an inventory that helps clinicians identify almost like the weakest link of the chain. So all 7 of these precursors need to be strong or reported in abundance, as you can see here for this in this last column. All of these need to be reported in abundance for the change to occur easily. And this inventory allows for discussion and awareness on the part of the practitioner and the patient of what might be the weakest areas or buckets that are the least full. Sometimes I like to say, and then to provide an intervention that is aimed at increasing the strength of that link or the water in that bucket. Here's scoring. And often we can find that the scoring discussion can be really valuable as well. So even saying, so what we see here is you've rated change to be at a 10. And what we would expect is that change is limited or that it may be kind of stop and start. Is that what you've been experiencing? And it allows for a lot of fruitful discussion. I think, I do move on right from this after this. So what I want to highlight for all of you here is with eating disorder clients, I often find that number 2, willingness to experience the anxiety and discomfort that change brings is often an area of a bucket that's the least full. And discussions around that of what might that feel like, being able to reorient around us SUD scale, subjective units of distress, really being able to get more perspective on the anxiety and discomfort that somebody might be feeling and what it might feel like in their body, looking for ways that they've shown resilience to this in their past. Also, hope for change is often one that is very low, and really being able to see a future where they can exist without the eating disorder. So that can be a strong place for intervention. And social support. And social support is not just what you would think, being productive relationships, but it's also looking at relationships that might work against the person supporting the change that they intend to. Okay. Oh, good. We've got some time. So this is the space where I hope that you have a little bit of paper around you, or maybe even your phone to do some notes. This is where I'd like to do a little bit of self-exploration for each of us, of exploring where we might be impacted and how we might show up when the change process is challenging. So this was the first slide I had, or one of the first slides. How do we respond when resistance shows up? So these were some of the ways that we saw resistance show up in our patients. And using myself as the guinea pig, these are some of the things that I noticed show up for me when I'm coming up against some of these barriers. I feel frustration. I can feel annoyed. I can feel resentful. I can feel critical of myself. I can put up a wall, and I can feel like I'm unsuccessful at my work. And I would like you just to see if any of those feel familiar to you. And then if you can identify even one, how do you show up? How does it change the way you show up in any relationship if you're feeling those things? And I want to go back to the session rating scale. I have had some of the therapists that I respect the most incredibly in my career say to me, I don't think I could ever use that in session. I don't want to know. I'm afraid for what somebody might say. And I really want to validate that as normal and scary, but also, I think logically a barrier to our success. Many of us that gravitate towards the helping professions want to feel like we're doing a good job, want to do a good job. And so to be told something that we're doing is not helpful or effective can sting. So what are some of the things that can come up? Oh, let me take a turn here. So taking that information in with receptivity requires us to show up with courage, with openness, to regard that feedback as an opportunity to learn, with respect and gratitude for the feedback that's coming our way, and without judgment. There are 3 buckets of information. There's what I know, there's what I do not know, and there is what I don't know that I don't know. And feedback can be regarded that way. So think of this kind of as a thinking error checklist or list, and some of the thoughts that we might replace it with. So in order to attune our reaction towards feedback to be one that allows for our growth, we need to be able to believe that all great clinicians are in the process of becoming, that at no time are we ever going to arrive with the heading master therapist. It's kind of like the idea of heading east. We never arrive at east, but it's always a direction we can move toward, versus a stagnant thought of, I must be as good as I am, as I'll ever be, or now, or I'll never be that good. Or the fact that I'm getting feedback that would offer me to change means I'll never be good. A strength thought and a growth mindset thought is, I'm only one ingredient, and how and what I combine with changes the outcomes. Versus, I must know how to attend to all aspects of all people successfully. I think pulled out, we would know that that's not reasonable. Also, being able to see feedback as valuable data that is in alignment with your values as a clinician, versus the thought that negative feedback is a sign that you're not doing well. And creating awareness of when our reactions, so frustration, resentment, annoyance, really is about our own human desire for control, approval, and security, and just creating space around that awareness. One of the tools that I really like for this to gain some awareness comes again from EFFT, and it's something called clinician traps. And there's 3 slides. So I would like you to, I'm going to read these off to you. And I just want you to circle the number, write down the number that any numbers that feel like they can apply to you. And I would really, again, like I said about the client, like you to kind of abandon logic here and sink into when I'm struggling, or maybe even think of a case that is a struggle for you right now. When I'm activated by the struggle, what am I believing? And these clinician traps are really what stops us from doing what we maybe know that we should do in care, or know how we should show up in care, what's serving as a barrier. So number 1, the fear of being disliked by a caregiver or a client, the concern of causing suffering to the client, the concern about going into an emotion without knowing what to do with it or how to process it, pushing a client or a caregiver too far, making the situation worse, or the symptoms, withdrawal, termination, suicide, leading to any of those fearful or undesirable outcomes. Making decisions that might be unpopular, but maybe even that you feel like could be wrong, or to the contrary of the wishes of the other treatment team members. This concern of bringing in a critical or dismissive caregiver that may lead to too much distress for the client, or having to face our own triggers, vulnerabilities, or wounds along the way. And lastly, being blamed or being to blame for the lack of treatment progress, including having a complaint filed. This one comes up a lot, a fear of licensure. Being concerned for being blamed by a client or a caregiver for the lack of progress. Fearing or looking incompetent or lacking competence. Not being good enough at our work. Or the fear of becoming overwhelmed or burned out. And then, of course, there's a space for you to have your own individual awareness of maybe something that comes up for you. And a space for you to think about when you are triggered, you're more likely to become, is it defensive? Is it withdrawn? Is it to be critical or to blaming of yourself or others? To avoid hyper focus on psychoeducation or research. I'm guilty. That's one that will make me dive into books and read and try to acquire all the information. Okay, so and pulling back the parts work piece, something that really has stuck with me is Dick Schwartz, the founder of IFS, has a statement, a very simple statement that says self pulls self. And what he means by that is that when we show up in self, we naturally pull that from our clients. So it's really important that we notice when we are not in self, that we have a keen awareness of when we are pulled from self and why we were pulled from self. And the reaction, is your reaction one of shrinking or puffing up? And that's Brene Brown's work. When I feel triggered or scared, do I puff up and get kind of maybe aggressive, or do I tend to shrink, get small, and try to fade into the background? So just awareness. What does it feel like when you're not in self? What happens when you're not in self? What takes you from self? And here is the precursors again for all of you. But this is through a little bit of a different lens. It's applying the precursors to ourself. So with that same client that you were maybe thinking about who is offering resistance or is maybe struggling with a stuck point in the change process, take a minute to rate yourself on these 7 precursors. So let's walk through this together. If you think of these as 7 buckets, where does the sense of necessity come in? So perhaps your bucket is low if you're feeling maybe indifferent or lacking a sense of interest, losing interest in that patient's situation. On the opposite end is your instinct to help strong. Are you continuing to stay interested and engaged? Are you willing to feel the discomfort and anxiety that might be a natural part of the change process? Are you willing, or are you concerned about feeling criticized? Are you feeling critical towards the patient? Are you feeling pain, or maybe is there something that is serving as vicarious trauma? How willing in this process with the client are you to experience discomfort and anxiety? What awareness do you have about what might be the things holding you back, or areas causing difficulty moving forward? Maybe it's deep resentment. Maybe it's feeling like you're not supported enough, or that you don't have the education or training to support this person. Your ability to continue to confront. So maybe you have that awareness of what's going on, what are the barriers, but you feel avoidant or you feel resistant to broaching those things. Maybe those issues feel uncomfortable or they're personally triggering for you. This is maybe where those clinician traps are showing up as barriers. You know what needs to be done, and yet you're afraid that if you do that, something fearful will result. Are you continuing to feel like you can put effort towards the change? How are you showing up in session? Are you able to maintain staying in self in session? Do you feel like you have the resources, the support, the supervision, the training that you need to put towards effort to maintain or help the client through the change process? How hopeful do you feel that this person can change? And I really want to highlight here, a lot of times we have to hold the hope for the client when they don't have it. And when we lose that lack of hope can be really contagious. It's easy to feel that from our clinician. And finally, how is our social support for change? We need our own support system. We are humans in this work, and we show up with human vulnerabilities. And so we need to be able to work with a team of professionals to have places where we're not therapists, to have places where our therapist hearts are nurtured, where our personal hearts are nurtured. So when you're thinking about the situation, how strong is your social support? Here are resources that I would love to offer all of you if you would like to just understand more. And I always say, so forgive me if you've heard me say this before, I love the eating disorder community because it is so dedicated to helping our clients. And with that, we are so willing to be collaborative and to be resources for one another. I have benefited from that in my career, and I would love to be a resource for all of you to continue to help patients as well. So here is where you can contact me. And I think, Jamie, we did pretty good for questions.
Excellent job on time. And we do have questions in the chat. The chat is going crazy with a lot of praise and support for you, Rebecca. They did want to know if you could go back to the resources slide.
Happy to. Yep.
Perfect. So with that being said, I will take a few of the chat questions. There are some comments, but I do want to look for some questions specifically. I think there was one that came in early in the discussion, and it says, what do you think contributes to the disconnect between the provider perception of the relationship versus the patient perception?
Oh, I've never been asked that question before, but it's a great one. You know, the very first thing that comes to my mind, and I like to put an asterisk that this may be one of those things that I'm laying in bed at night thinking about and would come up with a different answer. But the first thing that comes to my mind is ego. And again, like I want to always be my first guinea pig. I think we are people who want to be effective at what we do, who care deeply for people. And it's painful to think that we maybe are not doing our best for somebody, or that even down to our core, like this person's not liking us. So I think we tend to think that we are, aligning and attuning. I also think it's really difficult to tell a person, especially a person in a position to kind of be an authority figure, right? So Jamie, if you're my therapist, right, it's really hard to tell you that something that you're doing is a misalignment. And sometimes I think patients even think maybe they're the wrong ones. So when we can kind of introduce the idea that, like, I am going to need feedback from you because I don't know you. You're the expert on you, and you're going to teach me what's working for you and what's not. It makes it much less weird to solicit that feedback.
And I like what you said. I think it also plays a part into the relational concept, making sure that our clients feel that they can relate to us and that we're showing up in a way that our energy is open and receiving.
For sure.
Emily mentioned this has been my favorite webinar so far. It feels very practical and applicable. Also resonates with things I've been pondering currently as a clinician. Thank you, thank you, thank you.
Thank you. Wow, that was like made my whole day.
Let's see. We did get another question. I wanted to find it. There's so many things here on the list. We had a question about the recording. Good question. The recording will be available to you. So you will be able to access the recording. You can download it. So if you want to download it and store it, you will be able to do that through the remainder of 2023. So you have plenty of time to access the recording. We do have something from Jennifer Beasley. Hi, Jennifer. Good to see you in here. It says, yes, I think the willingness for anxiety and discomfort with ED clients comes from having to deal with the backlash from the eating disorder that comes on strong when the client attempts change.
Preach. Yes, absolutely. Such a good point, Jen.
Very helpful. So much gratitude. Are you able to go back to the conversation that you mentioned using your son as the example? Are there other tips or vocabulary that you can share with the attendees that may be having that conflict or that push-pull with family or clients that you think would be helpful?
Mm-hmm. In fact, I would be happy to share. I'm sure I have some slides on eating disorder relevance. So if anybody wants to email me, but being able to say, parents to say, it makes total sense that you want to cut right now, or that you're feeling a really strong urge to cut right now because you've used that as a tool for a long time, and because it has made you feel better in the past. And because you're experiencing a lot of pain right now, or a lot of sadness, or a lot of whatever. And I want you to know, so here's the emotional support. And I want you to know I'm here with you and going to help you ride this out. And why don't we go do something to take our minds off of this, right? Distraction. So where we might say emotional support, I believe in you, let's go do something different. But this really just adds on a chunk that creates so much opportunity for increased understanding on both parts. If I put myself in your shoes right now, I can imagine that you have no interest in eating your meal right now, or that you feel really angry about having to eat. Because your eating disorder voice can be really nasty, to Jen's point, right? It can be really mean to you because all of this change that we're asking you to do is overwhelming, and because there's a lot of new skills that you're having to put into practice. I really believe that you can do this, and we're gonna, sit down together and do this. Or let's set the timer so that you can make it through this quickly and we can just move on to the next thing.
Thank you so much, Rebecca. And the last thing that I will read, because we only have a minute left, Emily C. shared in the comments that I've seen resistance sometimes show up with my older clients being focused on my age as a younger clinician. Just yesterday, I discussed with a client like this, how the shame they hold for still struggling with their ED at an older age is really at the core of this. And working with the younger person has them confronting that. It's easier to make it about my age than the shame they feel about struggling with their ED still.
Exactly. That's kind of the heart of all of this is what comes up for them, what beliefs do they tell themselves about, your age for this particular thing, and then what things come up for us. I remember being the young clinician and also kind of internally thinking like, you're right, I have no idea. And worrying that was true. So yes, this is the exact heart of all of this. And thank you for that great statement.
Thank you so much, Rebecca. This has been an outstanding presentation. And again, if you will be so kind as to share your contact information for those of you that may have questions or other comments or would like to share them with Rebecca, please feel free to send her an email. And again, on behalf of myself and the entire Within team, we appreciate you taking the time to spend with us this afternoon. And we hope that you will continue to join us for the remainder of the summit and our presentations today. Thank you and have a wonderful day. Bye-bye.